Here it is. Oh, nice.
And we are now live, senators.
All right. Good morning. It is Senate Health and Welfare on February 22nd, very important day. Welcome. And today we're going to, continue our work on S37 markup. We're getting along in the bill and it feels pretty good. So I'm hoping that we can go through the rest of the bill and then we'll be ready for a vote soon. As maybe as soon as tomorrow. So Jen and Ameren, do you want to? We're on draft 2.1.
Yes.
You remember
Yeah,
what?
easier to have it in the back.
We are live.
Very much. They are not strong.
Okay.
Oh my gosh.
Do you know what?
I believe we left off, section 8 is where we're starting.
Section 8, yes. But a lot about section 8 is section 8 is missing. Okay, this is the,
Would you like me to screen share?
pardon me?
Would you like me to screen share the draft?
Yes, please. And it's on page 12 of the new 2.1. And it's on page 12 of the old 2.3. Okay.
All right, for the record, Ameren Abergele Legislative Council.
Jen Kirby, Legislative Council. Sorry.
So we're looking at section 8 in draft number 2.1 for S37. This is a markup version of the strike all amendment for the Senate Health and Welfare Committee. Once again, where you see highlighted bold language, that is the new language since last Friday, but not new since yesterday. So you see first, I have a placeholder here at the top of the new subchapter Pregnancy Services Center fraud for a findings section. And then there are no changes in the definitions.
Can I ask about that?
Yes.
The findings section? Did we talk about that in here? 'Cause you and I had a conversation before about not putting findings in.
Originally, we had a discussion about whether to put in findings with the first draft or whether to wait until we heard testimony. So at this point, having heard all the testimony, I think it would make sense to put findings in to explain, since we are aware that there is litigation throughout the country around these types of provisions, it makes sense to have sort of a clear statement of the state's interest in making this legislation.
Okay.
So it was more, we didn't want to get ahead of the committee's work and what the committee hears as part of the legislative process.
Right.
Okay. I remember the conversation a little differently, but maybe we could talk.
Yes.
Yeah.
So, go ahead.
No, just a question on what is the purpose of the findings section? It's just it's a new aspect of the bill.
Yeah, you don't often see finding sections in much of the legislation. When we anticipate that the legislation itself might be subject to litigation, it is helpful sometimes to sort of use the findings to summarize and pinpoint the purpose and the state's interest behind passing that legislation, so that if further down the line there is litigation, a court can look at the findings And in addition to all of the information that's going to be in the legislative record, such as all of the written testimony you've heard, all of the witness testimony you've heard in person, a place where the court could also go to see sort of a plainer statement of the reasoning behind the legislation.
That's all. That's-
So in this case, it would be with regard to some of the testimony that we've heard, in particular, the concerns that we've heard around the country, not just in our state. Okay. So we'll talk, why don't we leave the findings for now and come back to that, talk about how we want to deal with adding findings in.
So the next section where I made some changes in the Unfair and Deceptive Act, section 2492, the new section, beginning at the very bottom of page 13 into page 14. Here. As you know, this section adds a new subchapter into our Consumer Protection Act within statute. So I reviewed the other consumer protection statutes within Title IX and found consistently that there was no requirement that there be an intent by the person that the state does not need to show that the person intended to falsely or to, I'm sorry, so what happens at 8 a.m. That the person did not intend to make a false statement or to mislead someone. There is not that requirements in the other consumer protection acts. It just says if someone puts out advertising that is false or misleading, then the state can proceed based on that. It does not need to show that the person intended to put out a false statement or intended to purposely mislead someone. So I'm proposing removing this this intent language from in here so that this subsection A would read, it is an unfair and deceptive act in practice and commerce and a violation of 2453 of this title for any limited services pregnancy center to disseminate or cause to be disseminated to the public any advertising about the services or proposed services performed at the center that is untrue or clearly designed to mislead the public about the nature of the services provided.
Makes sense?
Are any more questions on that? The next subsection B, this is language that you saw previously last week from, this is a suggested change by the Office of Professional Regulation, saying that the medical director of a pregnancy services center or the individual charged with supervising healthcare services provided by center staff for volunteers at a pregnancy services center shall be responsible legally and professionally for the activities of staff and volunteers performing duties for and on behalf of the pregnancy services center. And there was no enforcement mechanism really here for this subsection. So what I added at the end, because what we're really talking about is healthcare providers such as a registered nurse or a doctor or a physician's assistant who works at the center. We're talking about their purview as a licensed healthcare provider. So I've added failure to conduct or to ensure that healthcare services are conducted in accordance with state law and professional standards of practice. They constitute unprofessional conduct under Title 30, Section 129A and Title 26, Section 1354. And those are the sections for unprofessional conduct for the professions regulated by the Office of Professional Regulation. And then the section for 1354 in Title 26 is for those professions regulated by the Board of Medical Practice.
Okay. Any questions there?
I put in a placeholder because there was discussion about a notice or disclosure requirement. I didn't know if the committee was going to circle back to that, but I just put a pin in it in case.
Notice and disclosure in terms of to the appropriate regulatory bodies?
Know whether the limited services pregnancy center would have to provide a notice to people coming in that they, what services they don't provide.
Got it.
Similar to the
Yes,
stem cell bill.
it is a
Yeah.
stem cell bill.
Yeah.
Let's just think about that. I think it makes sense to let people know what kinds of services are offered. Because people, don't know, frequently do not know.
Yes.
And what kinds of services
Are
are
not.
not offered.
I will say that
What is your?
point out that when we get into the area of notice and disclosure requirements, we are getting into another area of First Amendment concerns that have been the source of litigation, because it is the state requiring a private entity to say a specific statement that may not be a statement that the entity wishes to make. We did hear testimony from one of the pregnancy centers that they do in fact already notify people when they come in that they don't provide those services, and it is on at least some of the websites. So it may not be much of a further step to require it, but I did want you to be aware that this is another area that is potentially open to litigation. And these types of those requirements have been litigated in other states.
Yeah, this gets to a very value-based decision. And it also gets to, this isn't something that relies on FDA approval. It's not like the stem cells in that sense. So I'm willing not to put it in, given that there are a lot of other ramifications for other practitioners. Think about that. Anybody else is thinking, but I would say, let's move on for now, and we're gonna come back to that. We'll come back to that in the findings. To that and the findings. Let's see.
In subsection D, this is about the enforcement mechanisms for the Attorney General or State's Attorney. I made some clarifying statements following the current language, just to say for purposes of this chapter, advertising or the provision of services by a limited services pregnancy center is an act in commerce. The reason I put this in is that the limited services pregnancy centers do not exchange, there is no monetary exchange between clients that come to the pregnancy centers, at least the ones that we've heard from. And so the Consumer Protection Act often is based on commercial transactions. So we want to be clear that we consider this to be an act in commerce, such that it is a consumer protection. So I added that in.
That makes sense.
And then also added in that the Attorney General or a state's attorney has the power to issue subpoenas in connection with an investigation conducted pursuant to this subchapter.
Yeah, I think given that, then that reinforces my thinking on little c to not include it. I don't know if the rest of the committee agrees with that or not.
If you want to think about it,
Okay, we'll come back to
maybe
it.
talk to Amarin a little bit more about it.
Let's think about it. We'll come back to it.
So I'm just curious if this will be challenged at calling it an act of commerce, is that, I mean, it seems kind of a gray area. There's not a money exchange, there's a services exchange. I don't have any experience in calling something commerce.
There is case law to support this type of activity being a commerce, in that the entity is advertising for services that other, I won't say commercial entities, but other entities that do have financial interactions do. So really they're trying to build a client base, and from that they are taking customers in a sense from other entities that would provide those services.
Okay, good. Anything else? Okay.
All right, our next section is section 9. This is reports and interstate compacts. I almost forget to scroll on the screen here. So you'll see I have deleted the language that was in the last draft 1.3 markup that I believe was all in gray, and I said this language is going to change. So here is changed language. So first, subsection A, the Agency of Human Services shall include access to reproductive healthcare services and access to gender affirming healthcare services as indicators for equitable access to healthcare in its community profiles of health and well-being analysis. That's one. And then subsection B is the Green Mountain Care Board shall include reproductive healthcare service and gender affirming healthcare service needs in the health resource allocation plan analysis pursuant to Title 18 ESA 9405.
And if you go up to the community profiles for health and well-being on the Department of Health webpage, you can see how it will fit in.
Does it not already include those?
They are not called out as specific indicators.
Okay.
If you go to the webpage, they list out the indicators under each category of access to state services and health, access to healthcare services, and health of Vermonters is one of the categories. So I put it as indicators. I believe the data for the community profiles of health and well-being are updated, I believe, annually. I'm not sure how often they typically update their indicators.
So I'm just curious, there was in the previous version a product that was going to be delivered by a date. This is, what's the intent now with the new AHP? Is there an annual report that the Agency of Human Services provides? No.
No, but the HRAP is updated regularly by the Green Mountain Care Board, and as is the community profile, so it's accessible. We can review it as well as anyone else that wants to review it.
So there is,
Practitioners.
in effect, there is a product.
There's a product.
It's a subset of an old product, of the HRAP.
It's an improvement to the old product.
The E-Trap, though, my recollection is that they sort of do them on a rotating basis and have a different focus each time. I'm trying to remember the testimony we had, so that they'll do an HRAP of, orthopedic services and look at orthopedic services around. And then the next year they'll do dental services, well, maybe not dental, but they have different foci, and that they wouldn't necessarily do this every year, include it in the HRAP broadly, that they would have to do a specific HRAP on these services.
The HRAP is a resource allocation plan for all of the resources that have been identified for healthcare across the state. So the one we started with, this was hospitals and long-term care. And so if you ask the Green Mountain Care Board, we should clarify this. When we ask the Green Mountain Care Board for an update on access to any particular service, will they have that in a timely fashion? Will it be there for us? So this is saying to add whatever planning they're doing to adding these services. So that I think we should ask that question to make sure it's there.
I think if you wanted it to be done in an upcoming, you should direct that it wasn't the focus. They weren't going to be looking at all
Yeah.
services, then you may want to direct them and they can probably. give
Why
you a
don't we
better
do
sense
that?
of
Why don't we
the
direct them?
timing, because they may have already
Why
planned
don't
some
we
out.
direct them to update and maintain the HRAP?
I think they are
I
already
think they
required
do.
to update and maintain the HRAC, but the question is if they do a deep dive on a particular service type each year, you may want to direct them to focus on these
Yes.
service types in an upcoming
Yes,
report, but I think all of that would require
Yeah,
more
that-
information unless you know it from the Green Mountain Care Board about
Yeah.
how they.
yes, that's what I was saying.
Because I remember when we were talking with them about pregnancy centers,
Right.
they were explaining that they do this sort of rotation.
Rotation.
This is what I remember, and their website doesn't actually provide much information on how they determine what they do. So maybe having them in.
I don't think we'll have them in, but we can certainly have Jen and Amber connect with them and improve the language. I think we do want them to add this in. And we would like to ask for them to do this in the next year. I think that's the goal. I don't think we have to have them in to.
Okay.
Okay. Next section is section 10. This is first about the report regarding interstate compacts. You'll see the first change here in the first 2 lines of section 10. I have switched it so that the Office of Professional Regulation is the point instead of the Board of Medical Practice. As you know, we have additional compacts that are coming through. It seems like at this point, most of them are, the majority are for professions regulated by the Office of Professional Regulation. So I think it makes more sense for them to be the point moving forward for this report, but consulting with the Board of Medical Practice. And then I added some language in here to acknowledge that we may be contemplating more compacts and that it's not simply the 2 that the state is currently participating in that you want information on in the report. So the report requirement would now read, on or before November 1st, 2024, the Office of Professional Regulation, in consultation with the Board of Medical Practice, shall submit a report to the committees with findings and recommendations for legislative action to address any concerns regarding the state's participation or contemplated participation in interstate licensure compacts as a result of the provisions of this act, including the state's participation in the 2 existing compacts. To make that broader.
Okay.
The next section is an entirely new section, section 10A. So this would amend an existing chapter of Title 26. Currently, Chapter 56 is concerning out-of-state telehealth licensure and registration. They've broken this out into 2 subchapters. The first subchapter, out-of-state telehealth licensure and registration, and then a new subchapter 2, which would be interstate compacts, legally protected healthcare activity. So this would say, first in section 3071, legally protected healthcare activity, direction to Vermont representatives. And that's representatives to the compact, not to the House. Subsection A, the General Assembly finds that a state's prohibition on or limitation of legally protected healthcare activity, as defined by 1 VSA section 150, prohibits healthcare providers from following healthcare best practices and is a failure on the part of the state to provide healthcare services that are medically necessary and clinically appropriate for its residents. Therefore, is the General Assembly's intent to protect the ability of professionals licensed, certified, or registered in Vermont and applicants from other member states seeking to practice a profession in Vermont pursuant to an interstate compact or agreement to have the benefit of compacts and agreements, while at the same time engaging in providing or otherwise facilitating, personally or professionally, legally protected healthcare activity. Subsection B, Vermont's representative or delegate for an interstate compact or agreement related to healthcare shall seek an amendment or exception to compact language, rules or bylaws as necessary to recognize and permit the provision of legally protected healthcare activity in states which are participating in the compact or agreement.
That's going to be an interesting conversation.
Yeah, I like it.
This is good. Any questions about that section? So what this does is when our state enters into the physician compact, or the PA compact, or any of the OPR, advanced practice nurses aren't in it, but our nurses are in the nursing compact. So when we enter into that, we send a delegate to the full board of all the other states that are in the compact. And then that group writes rules about participation and what's allowed and what's not allowed. So we're saying that we have some protected health care in our state that other states may not have. And we would like to ensure that our practitioners are protected in those other states. So you can see if there's a state law, such as one in Texas or Alabama or others that prohibit abortion or restrict it significantly, then the discussion will be within the delegates about well, how do we, what do we do? So. Next meeting. I want to be at that meeting. No, I don't.
Question about contracts, I don't know much, but
Sure.
are they at all geographically bound? Or can we be?
In what way?
I mean, Texas seems far.
Yes.
But distance doesn't necessarily matter.
Well, you can have a license, with a compact license, you could practice medicine or nursing in that state with it's a reduced cost license, I think.
So anywhere in the country.
Yeah.
basically.
Or where any compact state, you have to join the compact in order to participate. We're gonna have a compact in here to look at after crossover.
Okay.
Which one is it? What's coming? to
There are
us?
several moving right now.
And there's 100
There's
of
the
them.
physical therapy compact.
okay.
There's the
Speech
counseling compact that
Oh, the
Katie
counseling
McGlynn
one, that would
is
be
working on. And then there is also the other one that I
There's an
just.
OT or speech therapist.
Yes, it's my
Okay.
bill even. Audiologist and speech language pathologist compact. So each compact, just so you know, has, the way the compact is formed is states that would like to join on, do join on, and those states are the ones that comprise the compact. So you could have states from all over the country. You could have some compacts that only have, say, maybe 15 states that have joined so far, and others that are up into the 30s.
And I'm assuming there's not one place where we could learn all about contacts on the web. They're probably each.
Well, there
separate.
is, I mean, and we do have a delegate, we do have a person who's responsible for compacts, I forget who it is. Ginger, do you happen to know who's? Okay, it's a new person, so as we go through the other compacts, maybe we'll have, I think it's a him this time, I don't know if it's a him or her, but maybe I'll have some.
Okay, thank you.
Yes,
Jessa Barnard with the Vermont Medical Society. Thank you. I just had it's maybe more of a question or comment about the language about what you would be asking the delegate to do, where it's saying to recognize and permit the provision of legally protected healthcare activity. I'm wondering if that encompasses preventing disciplinary action based on that activity, because the compact itself probably couldn't affect that state's laws about what's allowed or not, but it's the disciplinary and licensing consequences for providing that care. So if this language covers that, that's fine. I just was questioning if it was clear what you're asking that delegate to kind of advocate for.
I think that's a good point, but do we need to modify this?
Yes, I think
Okay.
I could clarify that language a little bit.
Are you ready to move on to emergency contraception?
Yes, and I just want to remind us that after we do that, after we finish off the bill, we're going to go back to two sections that AHS wanted to review. Ginger, that's you. Yeah.
Right, so you have not made any changes to the emergency contraception sections since draft 1.3. In fact, draft 1.3 was the one that had moved us from a separate process for a standing order for emergency contraception to instead embedding emergency contraception in the existing clinical pharmacy and prescribing statutes, allowing a pharmacist to prescribe, order, or administer, in this case, emergency contraception in a manner consistent with state protocol approved by the Commissioner of Health. No, that's okay. That's okay. I was sort of talking about what's already in there. So there's the state protocol language, existing language, and then it adds emergency contraception down there as number Romanet 11. And then section 11A is the emergency contraception in vending machines. And at the request of OPR in the last draft, we changed the board's requirement, Board of Pharmacy's requirement to adopt rules at the bottom of the page from shall to a may. So it allows the board, but does not require the board to adopt rules to regulate the location, operation, utilization, and oversight of vending machines and similar devices in a manner that balances consumer access with appropriate safeguards for theft prevention and safety. no changes, but just.
Can I ask you about that first section? In paragraph A, it just gives the,
Okay.
I'm sorry, page 19 at the bottom, section 2077. It just gives the authority to a retail or institutional drug outlet.
Right, which is here says they already have or are not prohibited from doing under.
Right, so could a college put one in, or?
Not specifically under this language. So you had talked or you heard testimony, I think at one point about some states putting these on college campuses. I
Yeah.
did finally hear back from the Vermont State College System, and they said they want permissive, not required language if you were to expand it to
Yeah,
them.
so it just seems like having them in more places than just like the local niche pharmacy, having them where the people are who might need it.
It is a good idea, but I think we should probably leave the permissive language in for now, and we can always.
Well, it's permissive language specifically for basically retail pharmacies, retail or
Right.
institutional drug outlets. So retail pharmacies or a pharmacy at a hospital or some other, that kind of institution, not institution in the college sense that we use later in the bill.
Yeah, so I think just adding them to that list, so it is a may, it's already permissive, they just aren't on the list to permit them to do it.
I'm fine with doing that.
Okay. Can you think of other places we might want to add that?
Let's do that. Let's do the colleges.
All right, so we'll
Get two things.
use sort of broad language on institution of higher education so that you capture,
Yes,
you allow it at public and private.
Yeah,
yeah, higher ed.
All right, and then we get to section 12. This is a section on higher education healthcare services. And in the last draft, we had changed the language from medication abortion readiness to reproductive healthcare readiness. And I'm trying to think what else we've done in the last one, and changed this from plans, some kind of a readiness plan, to just some reporting. And you had asked to add language around telehealth. So I've done that, and then you'll see the big changes come starting at the bottom of page 21. So I've added a definition of telehealth, which really just points to the actually to the chapter that Amory just had you in Title 26. It's the definition for purposes of telehealth licensure and registration, and it specifies that it means kind of live audio, video, telemedicine, audio only telephone, and store and forward. So then in section 2502, this would require each institution to report to, and right now it says Department of Health, although in talking to the Department of Health in the chair yesterday, I think there's an interest in expanding this to the Agency of Human Services, as there may be others in the agency better to do the compilation than specifically the Department of Health. So each institution would report to the Agency of Human Services annually on or before November 1st on the current state of its gender affirming healthcare and reproductive healthcare readiness, including, and then I took some of the provisions from your former list. So the ones that are in bold are totally new. The ones that are highlighted but not in bold kind of moved from elsewhere in your prior language. So here's what they would be reporting on: whether the institution has an operational health center on campus, whether the institution employs healthcare providers on campus, the types of gender affirming healthcare services and reproductive healthcare services that the institution offers to its students on campus, and the supports that the institution provides to students who receive those services. The institution's efforts to assist students with obtaining gender affirming healthcare services and reproductive healthcare services from licensed healthcare professionals through telehealth. The institution's proximity to a hospital, clinic, or other facility that provides gender affirming healthcare services or reproductive healthcare services, or both, that are not available to students on campus. The referral information that the institution provides regarding facilities that offer gender affirming healthcare services and reproductive healthcare services that are not available to students on campus, including information regarding the scope of the services that are available at each such facility, and the availability, convenience, and cost of public transportation between the institution and the closest facility that provides gender affirming healthcare services or reproductive healthcare services or both. Does that feel like it encompasses all of the items you wanted reported on? Is that are current people right now?
Can I go ahead and mention, transportation? I'm just worried that in rural parts of the state, public transportation is non-existent.
Exactly.
Because I thought we had talked about maybe the school providing transportation.
About what?
I thought we had talked about the institution providing
Well, that,
transportation.
they may well do that, but I don't think we can impose that in this bill.
Okay.
Yeah, but certainly if we see that there's no transportation anywhere in some of our campuses, then that's something to think about.
You could add to number 7, something just saying, and whether the institution provides
Let's do that.
transportation.
Yeah,
Some of them have like a shuttle service into
Yeah.
town, others don't.
and what's it accessible for? So this is a good point, Senator.
Thank you.
So then on or before January 31st of each year, this would now have, in yours it says the Department of Health, but potentially the Agency of Human Services compiling those materials submitted by the institutions pursuant to subsection A and reporting to this committee as well as the Education Committee and the counterparts in the House on the status of gender affirming healthcare and reproductive healthcare readiness at Vermont's institutions. Then we have section 13, which is, I've just made some conforming changes here so that each institution would submit its first report to the Agency of Human Services I have in my notes on or before November 1st, 2023, and the agency shall provide its first legislative report on or before January 31st, 2024. So in your next draft, you would see changes just making Department of Health, Agency of Human Services throughout those sections. And finally, we get to the prohibition on disclosure of protected health information. So there are a couple of changes that you'll see on the next page that I think are mainly clarifying changes. But we have these same definitions of business associate, covered entity, legally protected healthcare activity, and protected health information, the most referring to the federal law under the Health Insurance Portability and Accountability Act, HIPAA, and one to your new definition in this bill. And then it keeps this existing prohibition on a covered entity, but again, you've added a business associate from disclosing protected health information unless it's permitted by HIPAA. And then in your subsection C, we have this language saying in order to protect patients and providers who engage in legally protected healthcare activity, a covered entity or business associate shall not disclose protected health information related to a legally protected healthcare activity for use in a civil or criminal action, a proceeding preliminary to a civil or criminal action, or a probate, legislative, or administrative proceeding. And I've struck through that is adverse to a patient or to a patient's healthcare provider because it seems unnecessary to specify that. And really, it's the authorizations under here that will kind of dictate whether that information is disclosed. So unless the disclosure meets one or more of the following conditions. So the first is the disclosure is authorized by the patient's conservator, guardian, or other authorized legal representative. And then this may have been sort of inherent, but making more explicit. Or if the patient is a minor, the patient's parent or legal guardian. Or if the same existing language in section 2, the disclosure is specifically required by federal law, Vermont law, or rules adopted by the Vermont Supreme Court. Third, the disclosure is ordered by a court of competent jurisdiction. That just means it's a court that actually should have the authority to order that disclosure. And then we keep the parameters around federal law, Vermont law, or rules adopted by the Vermont Supreme Court. Number 4, haven't made any changes since the last draft. That's the disclosure to a person designated by the covered entity or business associate to be used solely in the defense of the entity or associate against a claim that has been made, or there's a reasonable belief will be made against them in one of these proceedings like we've listed above. And then finally, number 5 specifies that the disclosure is to Vermont's Board of Medical Practice. So I had thought that was sort of implied, but this makes it explicit that we mean Vermont's Board of Medical Practice or Office of Professional Regulation as applicable in connection with a bona fide investigation in Vermont of a licensed, certified, or registered healthcare provider. So this is continuing to empower our Board of Medical Practice and OPR.
Term competent jurisdiction.
It's a legal term of art.
Yeah, no, I like it.
Not a Jordan. And then it was pointed out by our very good close reading editors that in the effective date section, I had neglected to add an effective date for section 11A when I made a new section. So that is the vending machines. I will put that in as, I think, as on passage, if that works for folks.
Okay.
Yes, and I should say I added section,
Yes.
an effective date for
Okay.
section 10A. And the reason it's taking effect on July 1st, 2023 is that's when that's the effective date of the telehealth registration
Okay.
subject, because I'm putting it into a subchapter or a chapter that's already being added. I wanted those dates to line up so that I don't accidentally repeal language.
Thank you.
Good.
Everything that's in this draft.
All right, so that we've been through the bill. I think we've talked about everything except findings. What was the other one? Did we come back to it?
We're gonna find out a little bit about the Medicare Board and the ATRAP.
Yeah, ADRAP, and then Ginger Irish is here from the Agency of Human Services. And I thought we'd just stay where we are, and then we can talk about the sections that you're interested in, because I'm sure there'll be a conversation that happens outside of around the room, and that's how we work. So Ginger, there were 2 sections you were interested in.
Yeah, there's actually a third. So Ginger Irish from the Department of Vermont Health Access. Apologies for not being here in person yesterday. I just wanted to share and restate the department's position on a couple of specific.
So maybe tell us what page as you go through.
Yes, absolutely. So page 7, line 18A. This is the section about prior authorizations and the ability for Medicaid and other insurances to use prior authorizations. The department would like to keep this language in. I know there was discussion yesterday about removing it so that we're able to be both medically and fiscally responsible. This is a tool that we're able to use to review these services and ensure they're medically appropriate, and also that we're conscientious of costs because we are a public payer.
So this is Amber's section, but while she's pulling up the page, my recollection is you took this out not because you did not want to allow prior authorization, but because you did not feel it was necessary to call that out. So not having it in there is not a prohibition on prior authorization requirements. It's simply not specifically calling
So
that out.
nothing will change in your practice as a result of having this out.
Okay, our department's read was a little different. We were hoping to have the language in, but I understand that that's.
We don't say it for any other type of care. And I think Ameren looked and found only a couple types of care, and to call it out for gender affirming care and not for other types of care seems discriminatory to me.
I appreciate that position. We were looking when we developed this language in conjunction with private payers at those specific language that did call it out that Ameren found. So that was actually our model for the language we proposed for this bill. So just wanted to share the department's position that we would prefer to keep that.
Go ahead, Sen.
Where are the other places where it's called out? I'm just curious, just for comparison's sake.
They are, I believe Alex might have posted them for yesterday, the email that I sent you. Let's see if I can.
Can't remember what section. It's in an agency.
Is it posted out?
It should be posted
Oh,
under
I see it.
yesterday's prior
Yeah.
authorization language.
Prosthetic devices.
There it is.
Diagnosis and treatment of early childhood developmental disorders and.
Prosthetic devices, she's got it up on the screen.
Coverage.
I
Those are not similar to gender affirming care.
I would say the only one that has similar language is the diagnosis and treatment of early childhood development disorders. The other is just that it needs to be provided in the same manner as required either by any other covered benefit or for those benefits in connection with other covered medical care.
I remember prosthetic devices, that was good.
That's one of my first ones.
That was your first one.
that I read it.
I mean, it does make me call into question why we have the language specifically in there for the diagnosis and treatment of early childhood development disorders, but that's probably a whole other conversation. But
So, okay, so this will be a committee decision. Why don't you go ahead with your next topic?
Thank you very much. So the next section is page 9, line 16.
Page 16?
Sorry, page 9, line
Page 9.
line 16.
Line 16.
This is the cost sharing piece. And again, similar to the testimony we provided earlier, there are some significant operational challenges for the Medicaid program to remove cost sharing. I just wanted to remind the committee that copays are very limited for these services, $1, $2, and $3. There is a cap of 5% on copays that Medicaid members can be charged. So the limitations are that we have a antiquated technical system that's about 40 years old. And to make these changes, we would need to go in manually, one programmer at a time through our fiscal agent. And they would need to put in that this specific code for this specific diagnosis does not, cannot have a copay, cannot have any cost sharing. It would take many, many hours. And unfortunately, because of many competing priorities, we have other deadlines we are trying to make similar system modifications too. So there's an operational challenge for us there. The second piece is just to be aware that there will be a fiscal impact to removing cost sharing. I don't know the exact number at this time, but because we're a public payer, it may require an appropriation or an adjustment to the SFY24 budget. So I just wanted the committee to be aware that we don't have the same flexibility as commercials in that regard. And that I think that could be something worth considering.
So your recommendation is to take out?
To put back in, see the cost sharing.
Thank you.
Oh, sorry.
No,
I thought yesterday but the committee discussed yesterday taking it.
what did we decide yesterday? We
I
decided
thought that I watched after. I wasn't
something
able
about
to-
how it would
You
have.
talked about it, you hadn't quite decided.
Yeah.
yeah, we were talking about putting it back in and with the language about
High
high
deductible.
deductible plans.
And
I
HRA.
think you may have also talked about putting it back in just for commercial insurance and
Yes.
not for Medicaid.
Okay.
Yes,
Yeah,
yeah, so that's,
Thank you.
so that one, I think you're covered with that one, and we'll continue with the idea of commercial insurance and the high deductible. You see the language on that?
Okay, so leaving the, having subsection C on page 9 apply to commercial insurance, but not to Medicaid.
I'm not sure they've decided yet.
You have not decided that. Have you decided?
I think that's a good compromise, Madam
Yeah,
Chair.
I do, I
Yeah.
think what it is we're not affecting, we're not gonna touch Medicaid with this one, but we are going to ask this of our commercial insurers. And then there'll have to be some language regarding the high deductible
Yeah.
programs that have HRAs and HSAs.
And I think we heard yesterday from the commercial insurers that it probably wouldn't be very many people,
Right,
but for those people, it may be significant that they don't have.
So-
Thank you very much.
Okay.
Just, I wanted to make sure we were.
no, it's good that you're here, to verify this.
And the third piece is section 5, state plan amendment. That's on the same page, line 20. In previous testimony, I think we had requested to change it to shall seek a state plan amendment if needed, which I think is later in the language. I just wanted to be clear that the timing of that, so on the last page, it specifies a date. First, the state plan amendment. Does the if needed language also apply to the dates portion on page 26, line 3? Or does that language sort of supersede the previous if needed language, meaning that we must then seek a state plan amendment even if it is not needed?
To clarify, on line 5 on page 26, we have put in if needed at the end of that line, just to clarify that exact point.
Oh, great.
If needed, yeah.
Thank you. I didn't see that piece. Great.
Good point.
That was our last.
Okay, so can we quickly go back to, what were the two pieces that we had, 3 pieces now? One that Ginger, you just brought up with regard to leaving in page 7, the prior authorization for this particular situation. And then we also have findings. What's the other one?
The agreement and care board HRAP,
I think we're good on that one.
we were gonna find out how they work.
Yeah, yeah.
I would just like clarification.
We're just gonna say update it and talk with them how about that. See, that is pretty good.
If we're still talking about that prior authorization, I do not want that language in here. I think it doesn't,
Okay.
I think that it.
I was
calling
gonna
it out
ask
for
for, I was gonna
transgender-
ask for a straw poll from the folks. If you would like to leave that in, or yesterday we took it out, it's only in a very couple places, and so is there anyone who really feels strongly about leaving it in?
Can I hear one more time what the purposes of leaving it in? What the benefit would be, or anyone speak to that?
Yeah, go ahead.
Well, it would have the language in statute, which I suppose is a more weighty reason for the commercial insurer or Medicaid to back up their decision about limiting the amount, frequency, or duration of treatment. On the flip side, you did hear from the insurers that having the requirement that coverage be for medically necessary treatment, that medically necessary implies that in the commercial and insurance world implies that prior authorizations may be used in part to determine whether those services are appropriate for the person, depending on what services they've had previously that should take place before the next service happens.
I think we should leave it out too.
Okay. Anybody else? Is there anyone who wants to leave it in? I'm hearing silence.
So you believe, paraphrase Senator Wood's comment, you believe that the language on medically necessary covers the concerns of commercial health insurance providers? Is that how you try to summarize? Is that what it said?
I think it should really address both. I mean,
Yeah.
commercial and Medicaid, so maybe we've alleviated some of Medicaid's concerns, but the medically necessary language allows them to use the clinical, the utilization management tools that they typically use, which may include prior authorizations. It doesn't limit that ability to use prior authorization, but it does. As Ameren said, medical necessity is sometimes determined by requiring prior authorization.
Can you say that again?
Medical necessity is sometimes determined by requiring prior authorization. So there's some connection between the provider and the payer before the payer approves, authorizes the treatment.
So the insurance company can look at what the practitioner is recommending and then say yes or no.
There's a judgment being made.
It's a judgment being made, and it should be based on medically necessary,
Right.
whether it's.
Prior authorizations are often used to deny care. And in the case of gender affirming care, that it is something that is medically necessary, but is in some realms controversial. And I don't want to say that state law requires them to do prior authorizations, because it will then give insurance companies another reason to deny care to people who need it.
So, yeah, so by being silent, we're allowing for the usual practice. So, anyone feel compelled besides Ginger to keep this in? Okay, I think it's gonna come out. I need to go testify in another committee, and so Senator Weeks is gonna take over for a minute. I'd ask you to go on to the next place where decisions are being made. I think it's a defining section. Yeah, okay, I'll do that.
And although I can say quickly that my recommendation for, other than if you would like to have a discussion, you're certainly welcome to at this time, but I think for findings, because it does end up being sort of a wordsmithing activity if we do it in committee, that I work on findings
I
and
would please ask you to do that.
Bring
so
them in
we
for
can
your
skip
review.
that discussion in here, and then, I don't know what the next one is.
Decision point.
I think we're good, just the A draft.
Just the aircraft and then, yeah, and then.
Jessup Barnard would like to say something before I leave.
You may leave. I just wanted to get to the committee.
Get rid of me.
I apologize. I skipped over a comment I was hoping to make in the malpractice section yesterday on a small wording suggestion. I don't know if the committee is amenable to me just bringing that up at this point.
That's fine.
Thank you.
Take a break, take a break. and back.
On page 5, where it starts big F, little I, and then it goes through the reasons that a malpractice insurer could not adjust risk classification or premium charges. And our language suggestion is in, let's see, big 3. And actually, the committee brought this sort of gap to my attention and when you were discussing this section, where it may have been legislative counsel that pointed out that 3 only prevents risk adjustment based on final judgments against the provider, but it does not address if claims are made or settlements are made, which are actually much more common than getting to a full final judgment in a case. So VMS at least would request that rather than only saying judgments, that it say claims, settlements, or judgments against the provider, if the committee is open to that suggestion.
Good, that makes sense. Yeah.
Thank you.
So if I can, going back to the findings section, what's the process for developing findings? Do you develop a draft based on the conversations you've had over the past month or more, or what's the process?
It really depends. I think in this case, Amber's recommendation was that she put something together for your review, and then you can make changes as appropriate based on that. Sometimes it's easier to have something to react to than to try to come up with
Sure.
findings.
And then findings, when I look through the bill, and findings are in a particular section, it's not an introductory. It's relative to a particular section.
Right, in this case, they'd actually be codified, I think is where she's proposing to put them in, so that they would go in the green books along with the statutory provisions, as opposed to being what's called session law, which is just kind of in the act itself, but doesn't travel as easily with the, isn't as easily findable after the session is ended.
They didn't want me yet. They're gonna let me know. Good. Where are we?
So we had a recommendation on the change on page 5, line 14 and 15. To add the words after judgment.
Settlements.
Page 5,
Page 5,
line 14 and 15.
okay.
After the words judgment, add the words or claims or settlement. Is that
Okay, right,
correct?
We'll probably write it a little different, but yes.
whatever, so that, yeah. Okay.
And that's all.
Okay, now where are we?
And we had talked a little, just explained a little bit the process or the proposed process for findings that Ameren would put together some draft findings for the committee to review. And then you can make changes based on your thoughts on that, rather than trying to come up with.
Will you
findings.
touch base with the Green Mountain Trade Board regarding a draft to do that? And then is it possible for us to see a next draft Friday morning? Yes, okay. So what I'm, or before, I mean, if there's a draft beforehand that we can review and then come into committee, and we'll put S37 on the agenda for Friday, and at some point during the meeting, we'll try to find some time to have a quick discussion and possible vote on the bill. So I think that's where we are at this point. Okay, so let's do that. Wow, thank you both. This is not easy, and are there corresponding changes that need to be made in H89 as a result of what we have done?
Yes.
So how will we handle that?
I think when it's really in the definitions section, so once you have decided on a path here and approved the bill, we will certainly be in contact. I mean, we're already in contact with Michelle, but to show those changes to the Senate Judiciary Committee, and it has H89, so that they can just put them in their version, and then we can have the same definitions.
Okay. Okay, terrific. So I just want to make sure that when we vote it out, that it'll be somewhat firm. Our sections will be firm in 89 when they take it up. Good.
Yes, it'll be interesting to see if they propose additional changes.
Well, that's what I.
Beyond these, but then you'll need to.
This is where it gets to be interesting. Okay. And so thank you, and Ginger, thank you, and Jessa and Claire, and all everyone's here. It's been very helpful in the whole process. Appreciate it. So we'll look for that and keep our fingers crossed. Thank you. Okay. Wow.
Speak before the,
It's Jeff, nice.
Yeah.
Not yet.
Yeah, I'd like to. We can go offline.